अरे अरे भाई
So we have very interesting topics
सर को
lined
दिखाओ.
up. Our first speaker is Dr. S.R. Arvind. He's the Director and Chief Diabetologist at Dicon Hospital, Bangalore. He is also the course director for PG Studies of Health University, RGUHS and RSSDI. He's
बाद में
the
दो, अभी
past
दो.
president of
नहीं सर,
RSSDI
जैसे
वहीं पे कर.
हाँ
2016
इंट्रोड्यूस करेंगे ना
and the
आपको,
current president
ऐसे
of
वहाँ पर
Diabetes
चेंज हो
India.
जाएगा.
He has
तो
several
मैं अभी
papers
तक
and
लेकिन
has
लोड नहीं किया
conducted
है, तो
several
उस टाइम मैं लोड करूँ मैं.
trials. So
हाँ
over
पेन
to
ड्राइव है
you.
ना आपके पास.
Well,
हाँ
as
सो गिव इट टू हिम, ही विल डू
Tejas
इट.
and Manohar, I think I should have called both of them who did that particular thing. Okay, so the fun is out. They were
हेलो.
having a lot of fun, but
यस.
I'm here to talk only about the science because
यस.
that is something that makes us decide whether the modern sulfonylureas are really standing tall today and are they likely to be standing tall. Okay, now whenever I and you choose a particular drug, the kids game is over, so they have gone, so we don't have to worry now.
Sorry, I didn't get you.
We all have to look at the basic things of what are the properties of an
For which class?
ideal OAD. Let us straight away start with the glycemic action, durable glycemic
Uh,
control.
so
Okay, I'm
I'm
not comparing
maybe who have given
sulfonylureas
you
with
my
any other
number?
drugs here. I'm not even bringing in SGLT2 into this. Now, the contenders for a sulfonylurea is only what
So
we have
basically,
believed before.
I'm
Okay,
not
very
aware of the
simple.
things
The
as of
best in
now, and
class,
I'm in conference. So can I call
HbA1c
you
reduction
back
is the
later?
best as far as sulfonylurea is concerned. And
Okay,
everybody,
thank
even
you.
in this debate, agreed that we should not even talk about the efficacy of sulfonylureas because they're still the best. Now, it's next only to insulin, and everybody agrees. There's absolutely no dispute. Which is the best drug after insulin with respect to HbA1c reduction? It is sulfonylurea. Then why do you even want to retire your best? This is a question that I have been asking everybody. Don't retire your best. And they just said, अगर आप चाहते हो तो आप retire हो सकते हो. But why do you want to retire your best? Even now, if there is an Amitabh Bachchan movie, I mean, I would be the first one to be standing and taking it. Okay, we go to the next point. Important thing. Weight. Everybody is talking about weight. Let's look at what happened to the metabolic weight in Kerodena. All that you gained was 1.5 kgs at the end of almost 6 years. And the doctors here who have come to the conference have already gained 1.2 kgs after 2 dinners. Okay, and this is what it is. You know, you have to pick something and start blaming. You know, sometimes I feel, you know, these critics are like my wife, you know. When she finds nothing wrong one particular day, she says, the shirt is not matching you, you know. She has to pick something that day. I said, okay, ho gaya comment or is there anything else? Okay, you change and come. Okay, if that makes you happy, I'll change and come. That's what it is about the weight. You have to pick something. And look at this, 1.5 kg more than elongated participants. And that's a big point of contention. And I'll go back to advance and say glycoside, weight change was 0. Okay, now let's look at the next thing, you know, how the people bluff about sulfonylureas. Freedom from hypoglycemia as if it's a big problem. Such an unfair comparison. That means whoever talks of hypoglycemia will never be able to give insulin to their patients, because when once insulin is used, people don't even talk about hypoglycemia. Only when insulin is not used, you are talking about it. See, hypo is not a side effect of a drug. It is the effect of good efficacy. Okay, when DPP-4 came, I still remember, they said it does not cause hypoglycemia, especially sitagliptin. And when we did the Ramzan study in 5 countries, we showed sitagliptin arm actually had hypoglycemia. And that was the first time. And then the MSD agreed, yes, it does cause hypoglycemia. Now, any insulin, any oral agents, all patients, and this is the frequency of hypoglycemia. And I said, hypo is a good effect of the drug. All that it needs is education. If somebody complains about hypoglycemia, I complain about the doctor and say, look, you have not educated the patient about hypoglycemia. Why do you even talk about it? I will even skip this because there are some data to say that there's a very small difference, etc., etc. Let's come to the summary of the Kerodena trial. And summary, they very clearly said hypoglycemia with glimepiride was 3 times higher. I agree. They had the data or something like that to show. But what they did not show, all of us, was hospitalization due to hypoglycemia was higher in the linagliptin group compared to the sulfonylurea. Nowhere that data has been shown in the Kerodena trial. Cleverly hidden. 3 times higher, fine, but no death. Hospitalization was more in those who were taking linagliptin and hypoglycemia. Sometimes it's very clever medical writing which hides most of these things. And all about hypo, I mean, I don't even have to go about it because the titration was a little funny, 1 to 2 mg and from 2 mg to 3 mg and 3 mg to 4 mg. All this happened in 16 weeks and we never do this in our real practice. When you very quickly up titrate a sulfonylurea because it's a potent anti-hypoglycemic drug, the chance of hypoglycemia can be a little higher. And then somebody who wrote the protocol also wrote down and convinced FDA that 4 mg of glimepiride is equivalent to 5 mg of linagliptin. I have no idea till today. I have asked people, where the hell did you get this data that 4 mg is equivalent to 5 mg? It all depends on the pancreatic effects. So with this kind of titrations, it can happen, but in real world, you always start slow and gradually titrate over a period of time, making sure that hypoglycemia does not occur. And Kerodena, HbA1c was 7.2. With 7.2, I would start, if I had to start a sulfonylurea in my patient, I would start with 0.5 once a day. And then probably I will push it up to twice a day. And still teach the patients even with 0.5, if you get hypo, then you reduce it to half. I would not start with 4 mg like what they did in Kerodena. Advanced trial, severe hypoglycemia 0.7 with glycoside. Now, cardio safety. I think this was shooting in their own luck, especially the DPP4 group, because when they designed the CVOT for Kerodena, I don't know how the FDA also approved this. The bold step was to compare linagliptin with glimepiride. I think they thought that glimepiride would lose, and that never happened. 3-point maze, absolutely equal. Curves are hugging each other. 4-point maze, no difference between glimepiride and the linagliptin. And Lina had to say, we are not inferior to glimepiride. So we are not saying glimepiride is superior. Linagliptin said, we are not inferior to glimepiride. And again, hypoglycemia is something. Okay. Now there were charts of ADAs 2021, 2022 guidelines, and this is what ADA say. Why are our doctors not showing the RSSDI guidelines? This is something that, if there's any pharma person here, he should really ask this question. Why show the ADA guideline and say, look where your glimepiride is right at the end? Now the same big names from the American Diabetic Association, none other than Rosenstock, who was a part of the Kerodena, he very clearly said that at least now I know the cardiovascular safety. It should no longer be a doubt. And somebody, the past president of ADA, Dr. Robert Eckel, clearly said, I would take people off sulfonylureas, and if there was an option through the insurance that I could use other drugs, I was scared of hypo, but at least now this study has helped me that I can continue sulfonylureas very safely now. And that is coming from two great names in ADA, not coming from anybody in India. Well, cost effectiveness, I'm not even going to talk about it because we know 70% of patients pay out of pocket. And well, people can argue that okay, now generics have come, the generics are same, equal and things like that. But again, the efficacy of sulfonylurea is so good, And then when you start a DPP-4, a generic DPP-4, and suddenly the patient checks the sugars after 2-3 weeks, if the sugars are not normal, then he's going to change his doctor. So it's better to start a glimepiride, especially in Indians, cost effective, teach them all about hypo, and then it moves on. So a very important thing is a patient-centric approach, and this is something that we have known. A good physician treats a disease, a great physician treats a patient who has the disease. So today the role of modern sulfonylureas in type 2 diabetes continuum is there. It's going to continue. I'm sure it is going to be there for many, many years. Winners never quit, and anybody who wants to quit will never win. And with this great person who continues to act and thrillers for so many years, sulfonylureas have remained winners for a long time, and winners will never quit. And sulfonylureas in 2022 and probably 2030 or maybe longer will continue to stand extremely tall. And even in my practice, I don't even hesitate to start a sulfonylurea. Somebody elderly, hypoglycemia is a problem, staying alone, I cannot teach. Yes, DPP-4 is good, but otherwise, cost-wise, all otherwise, HbA1c reduction, everything, you look at it, sulfonylurea is the drug of choice. Thank you so very much for the patient listening. I end there because we are running late by almost 45 to 50 minutes. So I don't think there'll be any questions unless there's one quick question and then I leave.
Thank you, sir. Yeah, I have a question we can have from audience, if any.
ये सर का है अभी यहाँ पे था ना ना हैंड
I think the modern
चेक करो उनका
sulfonylureas,
उनका प्ले कर देना
glimepiride,
उनका पेन
one of the biggest advantages of
उनके
glimepiride
पास ही
is
है
it's available in a combination with multiple other things. Glyphosate is also a great drug, but it's not really cost effective like glimepiride. It is still a little bit more expensive. Still has to be given at least 10 to
अभी
15
ये दो
days.
का है फिर ये इनका है बस इनका खत्म
I
हो
don't think there is
जाएगा
any head-to-head trials between glycoside and
एक का आएगा फिर ये तीन
glimepiride
का
and
बस
glycoside, but both are good sulfonylureas. And glimepiride obviously is a little longer acting and became a little more popular.
Less dosing frequency also has.
Less dosing frequency also.
Thank you, sir. We will now conclude this and we will invite another speaker, Dr. Narayan Devgaonkar. He is going to take us through one of the most important topics in our practice, which we don't touch upon, sexual dysfunction in diabetes. Many times we fail to ask this question, and Dr. Narayan Devgaonkar will take us through.
excuse me
He is an MBBS from Aurangabad and with more than 30 years of clinical practice. He has many affiliations including RSSDI, API, MAPCOM, and he has written multiple chapters for medicine update on hydroxychloroquine, ABPM, many publications to his credit. I invite Dr. Narayan Devgaonkar.
Good evening. At the outset, I would like to thank Diabetes India for giving me this opportunity. I would like to thank my friend for his introduction. The topic which has been given to me is sexual dysfunction in type diabetes. Basically, in our clinical practice, day-to-day practice, we see so many patients of sexual dysfunction, but no one comes and tell you that I have got such and such problem. This is the great problem which we face in our day-to-day practice. And basically, when the patient comes to you, the history is very important, and you have to ask the leading question to the patient that whether you have got a sexual problem. Patient himself will not come and tell you that I have got such and such problem. So I will, in short, go through one of the cases which we see in day-to-day practice. It is a 48 years old man having a history of type 2 diabetes with since 9 years, and he had a history of hypertension also. He complains of generalized weakness and feeling less energetic since last 3 to 4 months. He reports frequent quarrels with his wife and his significant marital strife. He smokes at least one pack of cigarette a day, but follows all the lifestyle modifications, including exercise. And on further probing, he admitted to having an erectile dysfunction, which is very common, which we see in type 2 diabetes. Almost, it is 3.5 times more common than the patients who are non-diabetic. On further probing, he admitted to having erectile dysfunction, which is becoming progressively more disturbing, both his wife and himself. And he still has a strong sexual desire, but most times he cannot get an erection. On physical examination of this patient, his BMI is around 27.4, he is a little bit overweight, his blood pressure is normal, his cholesterol levels are high, which we see in most of the patients of type 2 diabetes. His HDL, LDL is normal, but triglycerides are high. HbA1c, that diabetes is not well controlled, his HbA1c is around 8. And he is on medications like metformin, glipizide, vildagliptin, metoprolol, and hydrochlorothiazide. What are the key questions in these patients particularly? What are the risk factors for ED in this particular patient? What are the treatment options which we have got? And should testosterone be obtained routinely in the initial evaluation of erectile dysfunction? This is as already I have said, sexual dysfunction is a problem in majority of the patients of type 2 diabetes. It is very common. Is underreported. Most of the patients, they don't come and tell you in history that I have got such and such problem. Is missed equally by patients as well as doctors, because doctors also, they tend not to ask this type of questions because of time and all these things. And when so many times patients come to your OPD, he is not interested to tell all these things. Is close to the heart of both, structurally as well as emotionally. What are the sexual problems, sexual health problems in diabetes? Mainly it is erectile dysfunction, which we see very commonly. Then there is a testosterone deficiency. But all type 2 diabetes patients, we don't investigate for testosterone. Then there is a loss of libido. Then there is a retrograde ejaculation and balanitis, which we see very commonly in type 2 diabetes patients. Patient usually present to your clinic with balanitis. In female, there is a vaginal dryness. There is a loss of libido and decrease or absent sexual response. As already I said, there is a high prevalence of erectile dysfunction in diabetes. It is 3.5 times more than non-diabetic patient. There are so many studies and analysis of 145 studies. The prevalence of erectile dysfunction in diabetes is almost 52.5%. What are diabetes and erectile dysfunction is a complicated connection, because diabetes complications are associated with endothelial dysfunction. Mainly there is when patient has got a erectile dysfunction, that is said to be the earliest sign because of the if you see the peroneal artery and brachial index, it has been reduced less than 0.6, and that is supposed to be one of the indicators of some cardiac problem, underlying cardiac problem. It can be distinguished as a macro or microvascular complication, and major diabetes comorbidities which lead to erectile dysfunctions are hypogonadism. It may cause less testosterone level. Then metabolic syndrome, that is obesity, hypertension, and dyslipidemia, which we see in almost all types of type 2 diabetes patients. And there is obstructive sleep apnea. So what are the organic causes of erectile dysfunction? It is either vascular, it can be neurogenic, it can be hormonal, or it may be because of penile injury, or it can be sometimes which the drugs which we prescribe in day-to-day practice, which I will be discussing in next few slides. What are the psychogenic causes of erectile dysfunction? Their depression is the most common cause. Then there is a performance anxiety, relationship problems, psychological problems, and psychological distress. What is the etiology of erectile dysfunction? It is whether it is a psychogenic or whether it is organic. Erectile dysfunction commonly involves a combination of psychogenic and organic factors. Pathogenesis of erectile dysfunction, psychogenic, is a performance anxiety you see in this type of patient. There is a depression, relationship problems. Then vasculogenic, there is atherosclerotic penile arterial disease, corporal venous leakage, or traumatic arterial stenosis or occlusion. Then endocrine problems or metabolic problems like diabetes mellitus, hypogonadism, hyperprolactinemia, sulfonylurea, subthyroidism, and end-stage renal disorders. Then neurogenic, there is spinal cord injury which we see after the accidents. Then end organ damage. Then there is iatrogenic problems because of most of the times drugs. What are the risk factors for sexual dysfunction in diabetes mellitus? It is mainly a poor blood sugar control. Then there is high levels of cholesterol, high blood pressure, and patients are overweight. Age of the patient is most of the times it is more than 40 years. Smoking and physical inactivity are other risk factors for type 2 diabetes mellitus causing erectile dysfunction. Erectile dysfunction is a marker of systemic complications, which already I have said is arterial disease. Underlying cause may be arterial disease. There is a strong link of retinopathy, intermittent claudication, that is smooth muscle insufficiency. Then neuropathy, there is a depletion of neurotransmitters, reduced nitrous oxide levels. Then there is endothelial dysfunction, which is a precursor of getting patient likely to have cardiovascular problems. And then there is compounded by lifestyle factors. This is the, when you see the patients of erectile dysfunction, don't forget that hypogonadism is so many times the problem. In such patients, you get a low levels of testosterone. But in all type 2 diabetes patients, this is the study which has been published, where you don't get low levels of testosterone because we don't test it. Unless the patient has got hypogonadism, we don't test the patients of testosterone levels. So in all type of type 2 diabetes patients, we don't test testosterone levels. Hypogonadism in diabetic versus non-diabetic men, which has been shown in this figure. In non-diabetic, it is almost 10 to 2.3%, and in diabetic patients, it is more than 34%. The testosterone diabetes connection is a symptomatic common ground of low testosterone and diabetes level. So low testosterone symptoms are decreased strength, loss of lean body mass, and osteoporosis. And in patients of diabetes, you see insulin resistance, advanced body fat, and elevated fasting blood glucose levels. Both these things cause fatigue, depressed mood, depression in sense of well-being, and sexual dysfunction. So these are the causes why we get erectile dysfunction in type 2 diabetes patients. Sexual health and function in women with diabetes. Sexual dysfunction is for women with diabetes is more common than for women without diabetes. Lack of vaginal lubrication, pain during sex, and inability for orgasm can be a consequence of high or low blood glucose levels. Higher rates of depression in people with diabetes can lead to low sexual drive. Wearing of diabetes devices such as pumps, glucose monitors, or lumps from lipohypertrophy around insulin injection sites may affect body image and self-esteem, and inconvenience of self-managing diabetes may affect the spontaneity of sex. What is the impact of sexual dysfunction? Whether it can be on the individual or on the partner. So there are on the partner it is anxiety, frustration, anger, and deflated self-esteem. So all these things, whether it is on individual or on the partner, it can cause a relationship problem. It may cause unhappiness on sexual relationship, impaired communication, sexual or non-sexual, violence due to jealousy, marital breakdown, divorce, and poor role model for children. So how you evaluate these patients of erectile dysfunction is physical examination is very important, particularly history is very important in these patients. Femoral and peripheral pulses, as we see in all type 2 diabetes patients. Then penile brachial index, which already I have said it is done by Doppler studies, where you see the index goes below 0.6, then it is said that this patient has got a erectile dysfunction. Then you can see for femoral bruise for finding out the stenosis of the arteries. Then visual field defects, focal neurological deficits. Then breast examination of these patients you have to see, and this patient has got a gynecomastia. Then penile stricture, then testicular atrophy also we can see, and features of hypogonadism. Do not forget the history, which already I have said. History is very important in these patients. The most important part is how you treat these patients. Most important is control of blood sugar levels, blood pressure, and lipid control. Address end organ damage, avoiding or substituting medication that may contribute to erectile dysfunction. There are some medicines which may cause erectile dysfunction. These medicines you must omit. Then once erectile dysfunction has developed, oral agents are considered as first line therapy. So what are the frequently used medications that are associated with erectile dysfunction? Mainly antihypertensive drugs, which we are using in day-to-day practice to treating patients of hypertension, because diabetes and hypertension are they are coexistent. The drugs which are used and cause erectile dysfunction are thiazide diureters, beta blockers, calcium channel blockers, angiotensin converting enzyme inhibitors. Antidepressants are very important. They also can cause erectile dysfunction. Then antiarrhythmics, e.g. digoxin, anti-androgens, and histamine receptor antagonists like cimetidine, which we are using in the past, and recreational drug agents of abuse, that is cocaine and marijuana. What are the treatment options of erectile dysfunction? Main is oral drugs on demand or daily. These are phosphodiesterase inhibitors. They are mainly used, that is like tadalafil, sildenafil are the drugs which are used commonly. And the patient's education is very important in these types. Whether you should replace with testosterone therapy in all these patients, unless there is hypogonadism, you are not supposed to give these drugs, like testosterone substitutes. Then you can use these implants and all these things in this type of patient. And the most important thing in this patient is the counseling. Erectile dysfunction is a common complication of diabetes. It can impair quality of life, self-esteem and relationship with partner, which can impact day-to-day life. Refer to psychologists for couple therapy, which will open up communication and ease tension. So management of erectile dysfunction and coronary artery disease share the risk factors like dyslipidemia, hypertension, smoking, diabetes, all these things. Erectile dysfunction may be a predictor and precursor of cardiovascular disease, and erectile dysfunction confers 1.46-fold increased risk of cardiovascular disease. Then men with proven or suspected vasculogenic erectile dysfunction or multiple vascular risk factors, especially diabetes mellitus, should be screened for silent myocardial ischemia. So these are the patients who have got erectile dysfunction are likely to go for the myocardial disorder, coronary artery calcium score, and coronary computerized tomography angiography. This is the consensus guidelines for management of erectile dysfunction. You can see here. And these patients should be treated. Mainly the counseling is very important in these patients. And you have to grade the patient whether he has got high risk, medium risk or low risk. Accordingly, you have to treat the patients if the patient has cardiovascular disorder in addition. Effects of novel anti-diabetic drugs, which are GLP-1 receptors, DPP-4 inhibitors and SGLT2 inhibitors, ultimately they improve the blood sugar level and endothelial function as well, which will try to improve their this erectile dysfunction. In summary, sexual dysfunctions are common in people with diabetes. It may arise from a variety of vascular, neurological and hormonal derangements. Sexual problems related to diabetes extend beyond erectile dysfunction and include sexual desire and ejaculatory dysfunction in men. Variety of sexual concerns are common in women, and management of underlying diabetic condition may markedly improve sexual quality of life in patients with diabetes. Thank you very much.
Thank you, Dr. Narayan. We have time for one question, if any.
Is there some role of low dose like sildenafil take?
There is a study which has been published. There is a role of tadalafil, low dose tadalafil. 2.5 to 5 milligram tadalafil can be used in this type of patient for a long term. So this can be used, but sildenafil, the effect is very short, it is 4 to 6 hours. But the effect of tadalafil, I think it is almost for 24 to 36 hours. So tadalafil can be used in this type of patients. Yes.
Hypertension drug of choice in ED.
Yes.
Drug of choice for hypertension in ED.
Basically, the history is very important. If the patient, almost all antihypertensive drugs are causing this type of problems, but depending on the history and quality of life of the patient, you can use the drug. Because almost all the drugs which we use in as antihypertensives can cause erectile dysfunction. There is no specific drug which can be used here, because almost all the drugs we are using in day-to-day practice.
Could not carry down that has got from itself the erectile dysfunction problem.
Yes.
So I think that should be avoided.
Yes, sir. Even beta blockers. Even
Beta blockers, yes. But not carry down has a specific problem with this CD.
Mainly it is the beta blockers which we are using very commonly in patients with diabetes.
But which beta? Not all beta blockers.
Not all beta blockers, but
basically bisoprolol.
Yes.
Isn't it?
Sir, as neglibolol releases nitrous oxide, can be choice of hypertensive in EDs?
I think so. You can. Yeah.
For tadalafil, what is the period of trial that you spoke of 5 milligram? Till what duration is it?
Actually, there is a trial which has been published almost it is a trial of almost 1 month. And there is not more, it is of 1 month trial. And they have said that it is useful. So long-term use of tadalafil is advisable in these type of patients. Even daily tadalafil is used, and depending on the patient's response, you can continue it.
So actually, in those group of patients, have they done the baseline LHFS and testosterone in all patients?
He is asking whether hormonal study, LHFS and testosterone need to be done in all ED.
No, it is not. It is not advisable. There is one study which has been published. They said it is not required to do in all type of patients unless the patient has got a hypogonadism.
No, but if you are not doing, how can you know patient is having hypogonadism? And suppose patient is having hypogonadism, you have not replaced
Then
with
the study which has been, just I shown the one study, they have said that because in non-diabetic as well as diabetic, you can get a low testosterone levels.
Also, diabetes itself is significantly associated with hypogonadism. Those who are diabetic, their free testosterone is low, and all studies have clearly shown in comparison to the normal population, those who are diabetic, actually they have increased risk of hypogonadism.
Yes.
If you are not doing a LHFS testo, suppose someone is having hypogonadism, you are not replacing with testo and you are giving tadalafil. Are you going to get the benefit? Probably not.
No, basically.
First you have to give testo, then you can plan for tadalafil.
Yes.
So if you are not doing a baseline hormonal evaluation, probably it's not a generalized thing for everything.
But as a, in general, in all type 2 diabetes patients, they are not advised to do a testosterone levels.
Absolutely.
Unless a patient has got a hypogonadism. So this was the study which has been published, and these are the recommendations.
Thank you, sir. We will start with another speaker. Thank you, sir.
Thank you, sir. Thank you.
We have another speaker, Dr. Amit Saraf from Thane. He is an MD physician and he will be guiding us through urinary tract infection when to treating diabetes. He is attached to Jupiter Hospital in Thane, head quality control Jupiter Hospital, international advisor India for RCP London, reviewer of BMG and Annals of Internal Medicine, MRCP London examiner, DMP teacher and MD examiner, National API of
While they are setting up the screen, I just want to answer the question on top of everybody's mind. कितना slides है? 15 slides. First slide has to be the title slide. Last slide has to be the thank you slide. So 13 slides. Okay, that is the question. When I was a delegate for years together, I thought a disclaimer should always say कितना slides है. So audience could plan their time. So 13 slides. Bear with me. Actually, my take-home message is in a single slide, but since to make up for the time, I have made a little of a presentation, so please bear with me. And another thing is, somewhere on the brochure it is symptomatic bacteria in a diabetic to treat or not treat it. There is no, so that's a no-brainer. My topic is asymptomatic, them is the A, so I think that's another point. So congratulations, I think at the outset to Mr. Dr. Bansi Sabu, Dr. Manoj Chawla, the entire team of Diabetes India 2022. I think a phenomenal job. There is a big round of applause and I think a wonderful job. Very well done for the entire team. As always, I start with my conclusion slide. If you have understood this, my job is done right on this slide. So what are we trying to conclude from treatment of asymptomatic UTI in a diabetic patient? What are we trying to say? UTIs are extremely common, but you need to look for them. You need to ask a diabetic. We look for sugars, we look for their symptoms. But why not a simple routine microscopy? Still one of the cheapest tests available in microbiology lab. Look for the UTI rather than waiting for the symptoms to develop. Second concluding message, treatment of UTI without a proper diagnosis may lead to an antimicrobial drug resistance. So UTI dikha, antibiotic diya, that's not the way forward. You need to actually find out if the symptomatology is there. Third point, treatment with antimicrobials obviously then should be as per the culture reports. So most of the guidelines abroad have to be as per culture, whether it's a blood culture sent out, urine culture sent out, any infection, any antibiotic of choice is strictly as per culture report. So we talk about so many guidelines here, physicians, all of us, we talk about ADA and so many guidelines. I think when it comes to antimicrobial policies of ours, we should as a consensus say that we need to send a culture on day of admission or the first consultation, and then we choose a broad spectrum and change as per the culture sensitivity. After that, only bacteriuria with symptoms of UTI should be treated with antibiotics to avoid the spread of drug resistance pathogen. And the last point, diabetic females, diabetic overweight and obese individuals are the patients with highest risk of UTI. So having said that, why is it that a diabetic has most common UTI amongst other patients? The ADA also says that not only once in the lifetime of diabetes, this patient has a lot of chance of recurrence of UTI as he goes along. And diabetic female, as I said, overweight and obese individuals are the highest risk. And why is all of that so? One, it's a high glucose concentration in the urine. We are all aware of that, and that leads to colonization. So because of the high sugars, everybody loves sugars. We love sugars, the organism also loves sugars. They want to colonize in the urinary tract and thereby grow there. High glucose concentration in the urine is leading to thereby a rapid and a rich bacterial multiplication. So they are alive and they are thriving. It's like humanity. It's like Bombay City, just alive and growing up. Skyscrapers coming up, sprouting up at every junction now. So that's how the organism, they're loving it. They love the sugar in the urine and they're multiplying. Top it off, a diabetic, the poor fellow, has immunological defects. He has impaired neutrophilic function. He has reduced T cell mediated immune responses, a lower level of prostaglandin E, which works locally there for innate immunity. The thromboxane B2 and the leukotriene B4 are also low in a diabetic. And a bladder dysfunction is going to contribute all of that to aiding formation of UTI. So that's why a diabetic does have UTI pretty commonly. What are the types we see? Asymptomatic ones. So these are the health checkup guys who walk into your OPD. They have a health checkup report, a lady most commonly, that typical pus cell count of 7 to 8, you ask her any fever, any dysuria, and she's absolutely asymptomatic, sugar's a little on the border. What do we do? So that's one category of people, asymptomatic infections. Acute cystitis, they run to you. That's a very, that's a situation which we end up seeing a lot in diabetics, unfortunately. Complicated lower UTIs, which are mostly as catheter indwelling devices associated ones, uncomplicated pyelonephritis and complicated pyelonephritis with urosepsis are certain types of UTIs we end up seeing. The pathogenesis we saw in a nutshell in the previous slide. This is a bit more in detail. There is contamination of the periurethral area with a uropathogen, sometime from the gut, most commonly E. coli. This organism colonizes in the urethra and migrates to the bladder. After that, two things happen: colonization and invasion of the bladder, mediated via the pili and the adhesions, and inflammation response to the bladder and fibrinogen accumulation by the catheter. All lead to neutrophilic infiltration, bladder bacterial multiplication, biofilm formation, epithelial damage, ascension to the kidneys, colonization of the kidneys, host tissue damage by bacterial toxins, and finally bacteremia. So that's how it ascends and causes a lot of problems in a diabetic individual. How do we diagnose all of this? So as the age-old dictum goes, midstream urine. Tell your diabetic to hold the sterile container, pass the initial bit of urine, then quickly collect in the midstream sample and then give it to the lab for examination. Pyuria is most likely seen. So what does pyuria mean? Just presence of pus cells in the urine sample. Sometimes bacteriuria is missed. So colonization in the absence of a pyuria on a microscopic assessment can suggest colonization. So don't forget this, instead of infection, especially when there is bacteria. So you can just find at times a sterile sample, but colonization can still be present. These are the samples you should need to send for culture examinations. Microscopic examination can allow visualization of the bacteria in the urine, and a dipstick test, very, very important for the presence of urinary nitrite. You have to see that on a urine routine. If the nitrite is positive, most likely some colonization, some infection is happening. And what do we pick up? Most common E. coli, as we said, fecal-oral contamination, urinary contamination, pretty much common. Klebsiella, Protea, Pseudomonas, the top four, which are majorly, as physicians, we dread these. Enterobacter aerogenans, Proteus mirabilis, the Citrobacter furundii, Streptococcus, Staphylococcus aureus, and S. epidermidis, all of them contribute to causing UTIs. How do we manage? Depends upon various factors. Are the symptoms? Is it upper UTI, lower UTI, presence of urological abnormalities, severity of the systemic symptoms, and whether occurring with metabolic derangements and renal function derangements as well. But mostly, in a nutshell, acute cystitis management is basically first control the sugars. Probably put in the patient in indoor management, start with insulin, control the sugars. Treatment is tailored again as per a culture report. First line before the culture comes in hand, nitrofurantoin, fosfomycin, and your age-old Septran. These are guidelines even today taken from the NHS. This is 2022 Jan NHS guideline. They still talk about Septran, your trimethoprim, sulfamethoxazole, not about a higher antibiotic. So nitrofurantoin, fosfomycin, and Septran will do the trick at times. Then the culture comes in hand, you tailor make as per the culture report. And second line, then you can shift to quinolones and beta-lactams as per the culture sensitivity. Pyelonephritis, the infection has gone up to the kidneys. Hospitalization, obviously, IV antibiotic therapy, cephalosporins, piperacillin, tazobactam, and carbapenems are the top ones. The others also use, and they are all guided by the urine culture report and sensitivity. This is my talk on a single slide. Do we treat asymptomatic UTIs in diabetics in 3 lines? 1, zero advantage found over some years of research. So to answer what I said first, a person walking into your clinic with a health checkup report, typical 54-year-old female, diabetic for last 15 years, some 8-7 pus cells in the urine, asymptomatic on the urine front, borderline sugars. Do we treat? No, because no advantage has been found in treating such a patient. That's the first point. Second, This leads to antimicrobial resistance. Remember that point. So just treating, then you try to get the pus cell count to back to normal, and it's somewhere as physician we need to see, because I don't know how many of you have encountered this. Most of the stringent health checkup guidelines are from pilots and army. So a lot of people come for fitnesses, especially would-be pilots and would-be army recruits, saying that my so-and-so officer is saying that till this count doesn't come back to normal, he will not give me fitness. So somewhere as physicians we need to know, and we need to write back that if it's asymptomatic and it's just going to lead to antimicrobial resistance, we will not put an antibiotic just to get the count back to normal. And the only indication for a asymptomatic bacteriuria in a diabetic to treat without symptoms is GDM, a gestational diabetes mellitus. Only indication, you are justified in doing so, obviously for the risks involved to the mother and thereby the fetus. Conclusion again, so UTI is pretty common, look for them rather than they looking for you. The treatment is as per proper diagnosis, and otherwise will lead to antimicrobial resistance. Treatment is based on the culture reports, only bacteriuria with symptoms should be treated, and diabetic female looked into, overweight people looked into, obese people looked into. As I said, 15 slide, thank you so much for a patient hearing. अभी लेट हो गया यार, डिनर का टाइम है, ड्रिंक्स का टाइम है, क्वेश्चंस सर तो पूछेंगे या
highly resistant, even carbar resistant assets. So what do we do in that context?
So that's a very, so first part of the question is easy to answer, that culture positive symptoms treat with a sensitive antibiotic. Second part of the question, which again as physicians we encounter a lot, self cholesterol sensitivity here, others are intermediate, mostly are resistant. I think mostly to look at the MAC is very important. Look at the minimum inhibitory concentration on the culture report, and sometimes even picking and choosing a resistant antibiotic with a choice, with a combination of another one can work, especially if you control the sugars well, repeat a urine routine, repeat a culture, try to find out more, and don't forget fungal colonization. Most of the time we fail to send across urine sample for fungal culture as well. We concentrate only upon the bacterial colonization, and sometimes a coexistent fungal infection can also be there. Yes, sir.
GDM patient with bacteriuria and that culture negative, which antibiotic?
Penicillin. Standard. Penicillin group, safe, yes, sir. Mostly advocated. All of them are very safe for a mother or fetus to be started.
How long?
Sir, till the culture is in your hands. If the culture is then negative, then a 7-day course should suffice. And then at the end of it, again a very valid point, when do we stop? Easiest answer, repeat a urine routine. Because GDM है asymptomatic है. Sir is rightly asking, symptoms in it, how do you stop, when do you stop? So ideally start the treatment at a urine routine microscopy and a culture, and then end of therapy 7 days के बाद simple urine routine, pus cell count is down, hopefully the bacteria are down, you can stop the antibiotic.
Dr. Nice, very nice presentation. Just you told the asymptomatic cases, culture negative, you have not to treat, but how to tackle that case? Because many times many female patients coming and showing the results, and they really headache to the physician.
So again, a very valid question. So ideally, you refer them to a gynecologist. The pelvic floor musculature of a woman post-pregnancy has become very lax. The orifices have become very lax. They will keep on coming to with routine and repeated UTIs. The gynac teaches them pelvic floor exercises. And that simple remedy actually goes a long way in preventing repeated UTIs in a woman, especially a woman. Because mostly due to pregnancies, normal deliveries, cesarean section वाले नहीं, उनमें हो सकता है, but mostly the normal delivery वाला, the laxity will keep on causing that rectal and urethral cross contamination.
Post-menopausal female, in spite of using all kind of precautions, having repeated candidal infections, in how long can we use antifungals and how should we proceed?
I'll have to scratch my head to answer that. So point is, as Dr. Devakar also mentioned in the slide, they have a dry vagina, a lot of problems happening because of diabetes and age itself. Hormonal deficiency and sugar rise is a bad combination for such a female. So ideally speaking, the answer to your question is dictated again by the cultures. You start with a fungal culture, isolate the organism, isolate the antifungal towards it, start the antifungal. End of 7 days or 14 days, you repeat a urine routine microscopy and decide then. That is what I would do, but then Gynacs are better well versed because they give a lot of local applications, vaginal pessaries and stuff.
So in spite of local pessaries, that patient is recurrently
No,
having.
no idea. Absolutely, anybody can answer this.
Just note if the patient is on SGLT2 meters, then they should.
No, she is not on SGLT2. Or she
खाना खाते ना बंसी भाई
Incidence of UTI in SGLT2.
Yeah, I know.
Yes, incidence of UTI.
We should. I'm sure Dr.
I'll meet you at the bar.
Yeah.